Our guest is Dr. William McCormick, a board-certified orthopedic surgeon, and he is with the Orthopedic Healthcare Associates. It's a pleasure having you with us today, William.
It's a pleasure to be here. Thank you.
Tell us a little bit about the Orthopedic Healthcare Associates.
We're a group of 4 orthopedic surgeons, Dr. Magestro, Dr. Eid, Dr. Molina, and myself. We're located at CMC General in the Health Pavilion.
Well, our topic today is hip arthroscopy. Dr. McCormick, what is hip arthroscopy?
Hip arthroscopy is much like knee arthroscopy in that it's a keyhole surgery, if you will. It's a way of seeing the inside of the joint and doing work with minimum damage to the tissues around it.
So tell us how you do this. Do you do this with a special camera?
Yes.
X-rays? What?
Absolutely. It's a day procedure, so you come in and you go home the same day. In the operating room, we use traction to separate the ball from the socket, enough to make it safe to get in with a camera, look around, and then do the work that needs to be done. After surgery, the average patient would use crutches for about a month and would be able to go home the same day.
So it's another type of hip surgery.
That's right.
Okay. And they learned some of this, did they, from the knee arthroscopy? Is that where it all started?
That is where it all started. That's right. Knee arthroscopy has been used for quite some time now. Hip arthroscopy really started out in the 70s, and as our equipment has improved, we're better able to see and better able to do. And we're learning more and more about problems that start earlier in life, and so that we might be able to avoid, say, hip replacements in later life.
So probably the last 15 years or so, more of the hip arthroscopy has been performed. Now, does every orthopedic surgeon do hip arthroscopy? Because most of them do knee arthroscopy.
That's right, that's right. Not every surgeon would do hip arthroscopy at this point. It's becoming more common. But it requires specialized training. There's quite a bit of information to learn and new techniques. The hip is much deeper inside than the knee, and so access is a bit tricky if you're not familiar with it. So I've got some extra hip arthroscopy training, but the average surgeon would not likely just pick up hip arthroscopy unless he or she went off for some extra training.
Well, the other thing is this takes specialized instruments.
Absolutely, yes.
And I'm sure those instruments have gotten better over the past 15 years.
Oh, the improvement is phenomenal. It's phenomenal. The things that you can do now, simply because you're able to see better. If you use the analogy of the shoulder, I'm recently trained, so I find, say, shoulder arthroscopy easier than open shoulder surgery. And that's simply because I've been trained with the newer techniques, newer tools, newer instruments, and we really do benefit significantly from every technological advance.
But you can do either.
Absolutely, absolutely.
And I would guess that both procedures work, but it's important because of the patient differences.
Yes.
What's best for one patient may not be the best for the other patient.
Absolutely. And it depends on what you're treating. If you're treating an arthritic hip replacement is the way to do it, and that cannot be done with an arthroscopy. If you're treating a hip that does not yet have arthritis and you're trying to prevent it, many of us surgeons find the improved access and visualization of a hip arthroscopy we find that it makes it easier to treat these conditions, and the patients get back to their activities faster.
So basically this is not a hip replacement surgery, it's a hip repair surgery.
Absolutely. There is a growing consensus that hip arthritis is caused by, in many cases, subtle changes in the shape of the hip, such that in the end they get arthritis faster. So we think that most people should have hips that last essentially forever, but that abnormal anatomy will make it not last as long and predispose them to hip arthritis.
Okay, now you've mentioned this a couple of times, that there's a difference between injuries versus arthritis.
Yes.
Okay, so are there certain, let's say, professions that lead to hip problems that you would use arthroscopy, or injuries? What causes it?
Well, there are, I'll talk about two major problems that we can fix with hip arthroscopy. Mostly those are labral tears. The labrum is a gasket, if you will, that goes around the socket of the hip, and its function is to share some of the load and to distribute the lubrication fluid inside. So tears of that labrum can be fixed, and also some anatomical problems can be fixed. Say extra bone on the socket side. So this is a normal socket. The hip moves, there's no problems. This socket has too much coverage. The hip moves, and two surfaces that should not rub together do. In this case, there's extra bone on the femur side, there's extra bone here, and so as the hip moves, there's a shearing force up here, and the hip is subtly levered out.
So can you be born with this problem?
Yes. We're currently working on studies. These take many, many years. We've identified a number of things that can cause this, but the vast majority, as yet, are still unknown.
Do we consider trauma the most common, such as a motorcycle accident or football or sports, soccer, this type of thing?
What it probably will boil down to is a patient with an anatomy that makes it more likely to have the problem, has an injury or a repetitive injury, such as sprinting, such as a baseball catcher that goes into a butterfly position to stop a ball in the dirt, or in Canada, or I guess in the U.S., you've got quite a good ice hockey team too, an ice hockey goalie going down in the butterfly position repeatedly. That motion tends to grind one bone surface against another that don't belong together, and with somebody who is susceptible to that problem, injury results.
So there are people who are more susceptible to having this?
Absolutely.
Yes. Okay. And that's a mechanical thing?
Yes.
Just like, you know, your eyes are different than somebody else's, your joints can be different than somebody else's too.
Absolutely.
So how often do you do these surgery? Well, let's put it another way. Let's say you have 10 young men, and they've all had injuries, and they're going to have something done, or at least explore their hips. What percentage of those would you do hip arthroscopy versus open surgery?
If there are 10 young men with no arthritis, in my hands, 10 of them would receive hip arthroscopy, if I thought I could fix the problem with an arthroscope. There have been some studies that show the same results if you fix these problems using hip arthroscopy as if you do an open procedure, a traditional one with a cut, which works very well. But I find there are some side effects that I prefer not to expose my patients to. But having said that, the best thing is to have the procedure that the surgeon is best at doing. And in my hands, I think that's a hip scope.
Okay. So that's a good point. A surgeon should not do a procedure if he is uncomfortable with it, or if there are two ways of doing it, he should use the one that he does the best.
Yes, absolutely.
It's just common sense. Is this something that we're going to see more of in the future because now we know about it? and we know it can be taken care of. I'm talking about the disease itself as well as the surgery.
Yes, absolutely. There's some idea that in the future there may be screening, much as we have screening for newborns, where we check their hips to make sure that they're developing properly. We may wind up with screening of adolescents to make sure that we identify problems before they become painful and address them. We are not yet at that level. We don't have the evidence to justify that sort of intervention, but I have a suspicion that that's where we're headed.
Okay, let's think about that. In all the high schools, for example, all the teams, the basketball team, the football team, they're all given physical examinations and we check their vision when they're hearing all these things. Can we perceive that potentially in the future, particularly in something like football or soccer, that they will start looking at these hips beforehand to see if somebody is more prone to have this problem?
Yes, yes. I think that's quite likely in the future. As it is now, I would not suggest to somebody that they have hip arthroscopy unless they have hip pain. So if I find the same deformity in two people and one has pain and one does not, I would not recommend surgery for the one who does not yet have pain. The reason being that the body is very complicated. We don't understand why some people do and some people don't get pain, but I think that we're getting there. And once we figure that out, I think we'll be able to help people out and hopefully avoid injuries, preventable injuries, during high school athletics, during midlife, people my age with hip arthritis.
Oh yeah, you're really getting up there, son. Wow. Okay, now, we have this person, and he has this, you know, you can see it, but you mentioned pain. This, I have it and I'm not having pain. So would you do anything, Jimmy?
No. No, if you have it but you're not having pain, I would tell you about the potential for the pain. You can then decide whether you would like to keep doing whatever activity is a higher risk for you. Let's say you're a catcher, and you may decide, well, this butterfly position I find myself in several times a day is high risk for causing me hip pain in the future. I also like playing third base. Maybe I'll play third base. And that's very reasonable to do, but it allows the patient to make the decision. I would simply give information and warn them and perhaps follow them if should they be concerned.
In many families, we find that many times the father's been athletic, or there are two boys in there in the same family and they're a little bit competitive with their sports. And let's say one of them develops a hip injury. Is there a familial thing that says that the other one is more likely to have an injury?
There are some conditions that run in families. As yet, we haven't figured out that it's a very strong association. But it makes sense that if your brother is injured for a particular reason, that you might check yourself out or have yourself checked out to see if you might have a predisposition to this sort of injury.
Are there, while we're on the subject, are there any particular hip problems that do run or have a hereditary basis?
They're less common, certainly in the athletic population, but yes, there are slipped epiphysis or what's called Perthes disease, where you can have enlargement of femoral head and some abutment of bone that shouldn't contact it.
But these are things you would know about beforehand.
Yes, yeah. Those are largely things we knew about ahead of time. The studies to show family involvement will take some time. We're only just now getting some early results back from longitudinal population studies. So you go out and you survey 100 normal people, and you say, well, who's got these misshapen hips. Who's got an abnormal hip?
Okay.
And we're just figuring out now what is normal. So we're very, very early on in this.
The family histories in many diseases are important, but also our life habits and lifestyle habits. Now, we're talking about normally, with what we're doing here, younger people.
Mm-hmm.
So is it proper to ask the question, does smoking or eating habits have anything to do with these problems?
We have not discovered any association. Now, certainly, one of the best healthcare decisions you can ever make is to stop smoking or
Yes.
never start smoking. And we would always advocate healthy eating and regular aerobic exercise, where you breathe hard, you get your heart rate up, and you keep your heart and your lungs fit.
Now, we're going to talk again about the pain. You mentioned that there is pain with this, and
Yes.
that if I didn't have pain,
Yes.
you wouldn't operate on me. But are there other symptoms other than pain that go along with a hip injury like we're discussing?
Yes, so apart from the usual groin pain and horseshoe-shaped pain, let's say around the side of the hip, aside from those, when you bring your knee up as if you're sitting in a chair and try to turn your leg so that your foot moves away from your body, the vast majority of people who have hip problems like this are unable to move their foot at all away from the body. It's just, they can get it to vertical, but they can't turn it out. And that limitation of motion is often because two bony surfaces are rubbing against each other when they shouldn't be.
Now, that would be a pretty easy exam. Is this taught to family practitioners how to check this? I know they check newborn babies for hip dysplasia. Is that
That's right. That's right.
Pull one out occasionally. But is this something that should be done during a regular exam for any person that's going to go out for some of these physical sports?
I think it should be. I think we're getting to the point where we know enough about this, and as part of a pre-participation physical, we ought to at least examine patients. We don't yet have enough information to tell somebody you will develop problems, or you will develop arthritis, or this will begin to hurt you. But what we can say is, we think you're more likely to, and that simply empowers our patients to make decisions for their health care.
Now, you mentioned this pain, like saddle pain, did you say? Or
It's a horseshoe-shaped
horseshoe.
pain. Patients will often say, Doc, it hurts right here.
Okay.
And it also hurts in my groin right there. Whenever I take a drive in the car,
Are these
when I sit down.
misinterpreted sometimes as cramps?
Absolutely. These are often misinterpreted as groin pain from groin pulls. And so you'll commonly see somebody who, with sprinting or with ice skating, who says, oh yeah, you know, I've got this chronic groin pull and it just won't go away. You examine them and you find that they've got no tenderness in the groin. Working the groin muscles doesn't hurt, but they've got some of these impingement signs or bone rubbing signs where you move the hip around and you find that the motion is limited, and the pain that's reproduced is the same groin pull pain.
You also mentioned grinding.
That's right.
I can recall I had a knee injury many, many years ago. I mean, when I'd walk upstairs, I could hear the grating of the bone against bone.
Yes.
So they might hear that?
Absolutely. The labrum and then the cartilage next to it, as those degenerate and start peeling off and start getting more and more damage, the surface goes from being really smooth to being rough. And so patients may feel those surfaces rubbing against each other, and it won't feel smooth. And they'll notice that they've got catching, they've got locking, so they have to jiggle the leg around a little bit to get it to go again.
Okay, so we talked about pain. There's some physical symptoms that can happen. Now, when you say they lock, we're talking about the hip now. What happens if my hip locks?
If your hip locks, most likely you'll find that you move around a little bit, you try to relax the hip, you move it back and forth a little bit in the small area that you're able to, and then it frees up. Some patients will say, I have to bring my knee up and around and out to the outside. There's a tremendous pop, it hurts, and then I can move again.
Now that's interesting. If somebody has figured out all those maneuvers to get it back in place, that means it's happened on a regular basis.
Yes, yes. Often these are athletes. Athletes are accustomed to pushing pain away and pushing through it. And so they'll do whatever it takes to compete. And normally we wind up seeing them when they're no longer able to compete at the level that they want to. And so we find that they've adapted very well, as best they can, to their problem. And unfortunately sometimes have fairly advanced damage.
Because they put it off.
Exactly.
Yeah.
These are competitive people. That's what they do.
Now, if you have somebody like the athlete that's having this, this could, let's say they're a professional football player.
Right.
This could affect their career.
Oh, absolutely. Absolutely. One of the most common situations I come up with is a semi-pro athlete who is just about ready to make that last jump to the big team, or up from the farm team up to the big team, and they've got this nagging injury that just is holding them back.
And let's say you go in and repair it with hip arthroscopy. Will they be able to continue their career?
There's a good number of studies now, not huge numbers of patients, mind you, but a good number of studies, particularly in professional ice hockey, that show about 90% of patients get back to professional leagues, and at about a year and a half afterwards, about 80% of them are still there. Now that's pretty good, considering that the average professional ice hockey career is 2 years. So following a hip arthroscopy, about 60% of them say that their athletic ability is actually improved.
That's interesting.
Yeah, and about 30% will say that it's not particularly different, but the pain is better. And unfortunately, there are downsides with every surgery, and 10% say that they're worse.
Okay, so let's go back again to symptoms. Pain, irregular positions or locking of the joint. If you have a suspicion, do x-rays or MRIs or anything like this help you with the diagnosis?
Absolutely. There are some special views on x-ray that are helpful. There are some special MRI techniques that are very helpful. But the first thing, of course, is to talk to somebody, get the story, find out when it hurts, what the pain feels like, and where it hurts, and then move on to things like examination. So, moving the hip around and finding the position that hurts, and looking for other problems that could masquerade or mimic this.
Okay, yeah, you have a joint and there can be more than one thing bothering it.
Absolutely.
So I've got pain and
Yes.
you're not sure what is causing this pain. Do you have any diagnostic tests that you can do to alleviate it or give you a positive or negative finding?
Absolutely.
What do you do?
So one of the major tools I use is an MRI where a special dye is injected into the hip. Now, at the time of injecting the special dye for the MRI, we can also put in some numbing medication. And afterwards, you keep track of your pain. And if you come back to clinic and you tell me my pain was completely better for 4 hours and then it came back, then I would say that's the cause of your pain. But if you said to me, it didn't really make a difference, then I would start looking very carefully at other sources of pain. Because while you may have the subtle anatomic findings, or we might have an abnormal MRI, that may not be causing your pain.
In these younger people, and that's what we're talking about mostly, there can be cancer of the bone in the joint. Is
That's
that
true.
correct?
That's true, yes.
Is that one of your differential diagnoses?
It's there. It's certainly there. It's very uncommon. The average orthopedic surgeon would see this maybe once in his or her career. So it's potentially devastating when it does happen. Fortunately, MRI would pick that up and be fairly immediately obvious.
Okay, now, I've been to you, I got pain, and I can't move my leg, and you've done all these things, and I had a positive test for the pain check. And you're going to do hip arthroscopy on me.
Yes.
Okay? What do you tell me beforehand, or take me through the surgery?
Well, you'd show up to the hospital the day of, having shown up a couple days before to do some tests to make sure it's as safe as possible to do the surgery. So you'd show up that morning. Our nurses would get you through the pre-op check. They would get you all ready. You'd get changed. And then you'd come into the operating room where you'd lie down on your back. The leg that we're going to operate on would be in a traction boot. We'd apply some traction so that we can separate the ball from the socket enough to safely get into this space to look around. We'd then look inside with a camera and confirm everything that we found on examination.
Am I under general, or is this done under a local and IV sedation?
Oh,
Or
no,
both?
you'd be asleep.
It'd be asleep.
You'd be
Okay.
asleep. I haven't met anybody yet who wants to see any of that.
Okay. Yeah, you're pulling and you're stretching. That in itself can cause discomfort.
Yeah, and the surgery takes somewhere around an hour and a half to 2 hours, so it's a long time to lay still, even if you did have good numbing in the area.
So, are you gluing something? Are you stitching something? What does the average repair entail?
So let's say the gasket, the labrum, is torn.
Okay.
I would go in and I would freshen up the bone here so that I get good healing. And then I'd lasso the labrum with some strong sutures, and then I would anchor it into the bone up here and here and here. And that would pull it back on. And then what I would do is I would release the traction so the head goes back in, and then I'd move the hip around. And I'd see, do we have extra bone on the femoral side that we need to address? And if we do, I would get a burr and I would remove that bone, and that would mean afterwards that you'd need crutches for a couple of weeks while the body strengthens the area that remains, and that would be it.
So are you going to give me pain medicines? Do I require that after?
Yes.
Do you use antibiotics? Because we're always worried about infection in bone surgery.
Absolutely. We do use antibiotics. I've not yet had an infection. They're very rare with arthroscopy. However, we do use antibiotics. And afterwards, you would get strong pain medications. The average person would be something like 3 days to a week on the pain medication.
So quickly, who benefits the most from hip arthroscopy and who doesn't benefit?
Young, athletic people with something that we can find that's definitely fixable, who do not yet have arthritis. They benefit the most.
Well, I want to thank you, Dr. McCormick, for telling us about this. A lot of people didn't know about it. I certainly didn't. And these new techniques to repair our broken bodies.
That's my pleasure.
This is Dr. Richard C. Ratchett, hoping you'll see a bright day.